Hello, good evening, everyone, dear colleagues and friends. My name is Dr. Jihad Inshasi. I'm consultant neurologist at Rashid Hospital in Dubai. And it gives me a great pleasure to welcome you and thank you for joining us in this scientific webinar on neuromyelitis optica spectrum disorder. This webinar is one of the educational activities of the Emirate Neurology Society, EMENS, and thank Dr. Sohail, the president of the EMENS, for the support of these activities. The topic tonight is, as you see, the agenda here is interesting: recent advancement in diagnosis and treatment of NMOSD. And the agenda here will join us virtually two distinguished speakers from the Emirate and from Hopkins from United States. I'll go through the agenda in a minute. This webinar is sponsored by Biologics, organized by MCO and endorsed by the EMENS. Thanks for all for their contribution. This webinar is an interactive one. So we encourage all the audience to submit their questions or comments in the Q&A button. You see it down the screen. And we will be more than happy, the speakers, to address and answer your questions. This webinar is CMA accredited, so you will be notified by the MCO on how to get the certificate in due course. So will join us distinguished speakers. The first speaker will be Dr. Ahmed Shatila. He's senior consultant neurologist, and he will be talking about disease overview and differential diagnosis. Dr. Ahmed Shatila is a consultant neurologist at Sheikh Shakhbout Medical City. He is American board certified in neurology and neurophysiology, and he manages all the MS patients in his clinic. And he is a distinguished speaker and well-known expert in the region. Dr. Ahmed, the floor is yours.
Dr. Jihad, thank you for the kind introduction. First of all, good evening, everyone. I'd like to thank EMENS for organizing this event and offering me an invitation to speak. I'd like to thank Biologics for giving me the opportunity. And finally, the attendees. Without you guys' support, none of these conferences can ever happen. So thank you all. And of course, the organizers, MCO as well. So let me share my screen. Okay, so there we go. So I'm going to talk today about disease overview and differential diagnosis. An overview of NMOSD. I'm Ahmed Shatila. I'm a consultant at SSMC. So here are my disclosures. So when we look at NMO, NMO is a rare, progressively debilitating autoimmune disorder of the central nervous system. Now, what does that mean? How does it present? You know, NMO predominantly is optic nerve spinal cord, and that is historically what we think of as NMO. But we now know that NMO isn't just optic nerve spinal cord, it's also got some brain involvement. It has brainstem involvement as well, especially the area postrema. So when we talk about symptoms, what are the symptoms that people can have when they have NMO? Fatigue, very common. Pain, up to 80% of people with NMO can present with pain. A radicular type and electrical type pain, neuralgia, they can present. You get the bladder bowel dysfunctions from the myelitis. You get the motor disability, of course, when you got these longitudinally extensive myelitis. You have visual impairment because that's almost the hallmark of the disease. It's an optic neuritis with spinal cord involvement. And then you get the nausea, vomiting, and hiccups, which is predominantly from the area postrema syndromes or the roof of the fourth ventricle. Interesting enough, the medical terminology for hiccups is syngultus. I learned that a couple of years ago, and there is actually a word for hiccups, it's syngultus. So when we look at what's this NMO disease course, NMO is predominantly a disease of relapse. It's relapse where you get relapses followed by periods of remission, but during every relapse, the disability begins to accumulate. And as it's accumulating, you're getting neurodegeneration, almost in a stepwise process as well, because again, in between attacks, patients are well, there's no issues. But you know, when they get a relapse, they lose brain cells, they lose myelin, they lose axon, they get so that you lose an overall quantity of your cells, and you get more disabled. Now, What's the prevalence? It's a pretty rare disorder, 0.05 to 13 per 100,000, and the age of onset is mid-30s. Half of patients with NMO do require the use of a wheelchair or become functionally blind within 5 years, and 40% of people with NMO are initially misdiagnosed as MS. NMO is not a more severe form of MS. It is a different disease altogether. NMO is an autoimmune disease, as I said, of central nervous system, predominantly optic nerve, spinal cord, and brain. During the NMOSD attacks, it's unpredictable. They tend to be severe, tend to be recurrent, and overall the disease, usually the functional recovery after every attack isn't like MS where people tend to get better after attack. This is a very destructive, very inflammatory disease with very little recovery after attacks. Attacks can result in cumulative disability with devastating consequences, potentially leading to blindness, paralysis, pain, depression, and overall mortality. Back when I was a resident, we used to say that, a significant portion of people with NMO would be dead by 5 years due to respiratory failure or secondary infections. This is not your mild or your more devastating forms of MS. It's a lot more severe and it's a different disease. What's the underlying process in NMO? It is felt to be a complement-driven disease. You do have an antibody, which is the aquaporin 4 IgG, which crosses the blood-brain barrier and binds to aquaporin 4, which is on the astrocyte foot process. Now, astrocytes are important for helping form the blood-brain barrier. And so when you get inflammation or you get cell-mediated or antibody-mediated damage to the astrocytes, you get leakage of the blood-brain barrier, you get destruction of that, then allowing the antibodies to come in, and this is where complements come into play. Normally, you got the C5a, binds to C5, forms C5b. Aquaporin 4 IgG binding activates the MAC formation, thus causing the demyelination. All of this, what's the end result? You get the astrocytopathy, leading to neuronal destruction. As seen in NMOSD, activated complement leads to astrocyte death, inflammatory damage, and ultimately neuronal death. Once it's dead, it does not come back. So when you look at this little video right here, you can see this is a very fast forward. The arrows are what I want you to keep in mind. The arrows are your astrocytes, and as you can see, as we go through time, the astrocytes swell up, they die, and on the right side of the screen, you have the controls, the healthy controls who don't have NMO, and those astrocytes are healthy and well and doing fine. When you look at this video right here, you can see the myelin is in green, and as time goes by, you get myelin destruction, demyelination. There we go. So how do you diagnose NMO? According to the 2015 International Panel of Neuromyelitis, the International Panel of Neuromyelitis Optica Diagnosis, this was in 2015. So how do you diagnose NMO? Basically, you have, first of all, in order to diagnose NMO, you have to have the AQP4 IgG antibody. You have to have that to be saying that you have AQP4 positive NMO. Once you have the antibody, you need one core clinical characteristic. You need the optic neuritis, myelitis, area postrema syndrome, which I told you are the hiccups, intractable vomiting. You got to have the acute brain syndromes, symptomatic narcolepsy, acute diencephalic clinical syndromes. You only need one of those. And you have to have nothing else that can explain it, such as MS, sarcoidosis, or neoplasms. It is a long journey to diagnose NMOSD. On average, it's 3.3 years before the patient shows up with their first symptom to they see a neurologist who can actually diagnose them. It's not because, this road is complicated. It's not easy. They may end up seeing their optometrist first thinking, I have blurry vision, when in fact they have optic neuritis. They may see their internist, or they may go to the urologist saying, I have bladder problems. So it's a long, windy road. And on average, it's a 3.3-year journey before time of symptoms to diagnosis. What's the most common disease that people mistake NMO with? It's MS. So when we look at NMO and MS, what are the two populations? First of all, globally, NMO has a relatively similar global prevalence, except for one country in the French Martinique, which has a very high prevalence of NMO. Now, I know there was a reason to it, I'm not quite sure why, but that country in particular has almost a tenfold increase of NMO compared to everywhere else in the world. MS, as we know, it's a prominent European North African population. NMO tends to be more older. The average age of diagnosis is 39. With MS, it's 29. NMO is optic neuritis and myelitis, while in MS, it's entire CNS. Spinal cord in NMO, it's greater than 3 vertebral segments. While in MS, it's a short segment. It's not greater than 3. When we look at biomarkers, more than 75% of people with NMO will have the AQP4 IgG positivity. While in MS, we still are looking for that elusive biomarker. We have not yet found it. We got the oligoclonal bands, but that's not specific, just for MS. Disease course, 80 to 90% of people with MS or with NMO will have a relapsing course, and it's very similar to MS, that's around 85%. What about the severity? NMO is a relatively very severe, repeated acute attacks. NMO with MS, some attacks can be mild, some can be acute. It's not very consistent. And with NMO, the disability accumulates with time. While in MS, sometimes you have accumulation of disability, sometimes there's improvement. And finally, with NMO, there is a coexisting autoimmune condition. It's very common to see positive ANA or ENA. While in MS, it's not very common, it's rare. So when we look at the imaging of people with NMO, the image on the left, you can see that bilateral optic nerves posteriorly are highlighted. There are T2 changes in the posterior portion of the optic nerve bilaterally, usually extending to the optic chiasm. When you look at a patient with MS, usually it's unilateral, usually it's anterior. So that helps you a little bit distinguish NMO lesions versus MS. When you think of chiasmatic lesions, think of NMO. Think of posterior lesions, think of NMO. What about the spinal cord? How do NMO lesions in spinal cord look different than MS? On the image on the left, you can see this very longitudinally extensive myelitis extending all the way from the area postrema, from the roof of the fourth ventricle, all the way down to the upper thoracic cord. Usually this is a very continuous, very central lesion. When you look at MS lesions usually do not include more than 1 to 2 vertebral segments. And when they do, they tend to be more peripheral. NMO lesions are central, they're long. MS lesions are peripheral, and they're more central. And they're more shorter. When we look at axial sections of imaging in NMO, you can see in the axial sections, it's like I said, it's a centrally mediated, it's more centrally mediated. It also tends to, include the gray matter. You see gray matter, and actually just yesterday I saw a patient with NMO, and it was interesting that her gray matter was much more affected than her white matter, and you could almost trace the dorsal columns, but she had a history of myelitis, INO, hiccups, nausea, vomiting, and she had this very extensive transverse myelitis extending from C3 all the way down to T1. While you look at MS lesions tend to be more peripheral, and they're not like the same image, and they tend to be shorter, not like I told you with NMO. So how do we diagnose it? There are 2 ways to diagnose NMO. There's the older ELISA-based, and there's the new cell-based assay. Now, ELISA is short for enzyme-linked immunoabsorbent assay, and then you've got the cell-based, which has a higher sensitivity and specificity. Now, cell-based, so that's one thing you need to keep in mind, that if you do the NMO, if you do the AQP4 test and it's negative, check out what test they did, what assay. If it's the ELISA, do the cell-based. If it's a cell base, it may even be prudent to repeat it in a couple months because sometimes it can be negative. And after repeated attempts, it can be positive. It's the most common disease. NMO is most common in women at the average age of 39 years, as I told you. More than 3/4 or 73% of people will have an AQP4 IgG positivity. 92.7, 93% of NMOSD patients with the AQP4 antibody will have relapses. NMOSD is more common in females than male. So think females, think older females than, older in the sense, older than your typical MS population. Think optic neuritis, acute myelitis, and ask about hiccups, intractable vomiting. And then ask about, do they get better with steroids, which is interesting enough, some of them actually do. Incidence of NMO is 2.5 per million per year, and the global prevalence is around 25 per million. It's often misdiagnosed, as I told you. Nearly 2/3 of patients reported having NMO are initially diagnosed as something else. Most commonly, it's MS. Again, of those misdiagnosed, as I told you, 64% of those are told that they have MS. Now, why is this important? Because when people with NMO are diagnosed with MS, they're treated like MS. And the problem with that is that the drugs used for MS can actually make NMO worse. And what are the drugs that can make NMO worse? Interferons, natalizumab, fingolimod, all have been shown to make relapses worse or exacerbate relapse or actually do not work. So that's why it's important to differentiate whether your patient has NMO or he has MS, because if you're going to treat, potentially your disease treatment for MS can make them worse, or potentially there's been case reports of people that have had hemorrhagic encephalitis after being treated with alemtuzumab, who turned out that they had NMO. So it can't even be fatal treating your patient with the wrong medication if they have NMO. We have a need, and the need remains. We need early, accurate identification of NMOSD patients. We need proven effective treatments to prevent relapses and improve symptoms. So what do we need? We need better knowledge, improving understanding of the disease that enhance patient outcomes. We need support, optimal management of disease with evidence-based methods. What about the diagnosis? We need to improve diagnostic procedures to enable rapid and accurate patient identification. We need wider symptom controls. We need to reduce the need for treatments to manage wider symptoms, such as pain, which is very common, fatigue, which reduce the quality of life. Finally, maintenance treatment. We need treatments that are consistently and effectively able to prevent relapses and improve the quality of life, improve mortality, and prevent relapses. So in the UAE, when we look at in the UAE, we have a number of unmet needs for NMO patients. And I'm going to talk a little bit about this in the few remaining minutes. First, when we look at awareness and epidemiology, the ones in red, or I don't know, salmon color that is, those are the high priorities. The ones in like an orange mustard color are medium importance, but they're still important. We need to improve awareness among our healthcare practitioners in the medical community. We have low awareness among patients about NMO. There's low awareness among the community and the population, and there's absence of patient registries in UAE and information on patient numbers about NMO. No one really knows how many NMO patients actually exist in the country because we don't have a registry. Healthcare, in regards to screening and referrals, we need healthcare practitioner education, training, and on-screening and referrals. We also want to prevent delay in appointments. As I told you, it's 3.3 years. What about diagnosis and testing? We need to have better testing, education, and training on the diagnosis. We also need to help educate our optometrists. We need local labs, quicker turnaround of the results with MRI appointments. And then finally, treatment and follow-up. We need established treatment for the diagnosis. We have lack of patient initiatives, PSPs, and lack of support groups. 41% of people with NMO will be legally blind in one eye after 5 years. 9% will be legally blind in both eyes. almost 20% would need a walker by 5 years, and 8% will need a wheelchair. In the end, 76% of patients did not fully recover from the first myelitis attack. And within 1 year, 35% of patients required an ER visit, many of whom had multiple visits. 2.8 ER visits per patient on average. 22% of patients required inpatient admission. And finally, 7.8 days were spent in the hospital per admission. Last but not least, 81.5% reported relapses requiring hospitalization. And this is talking about pain and anxiety, which both are extremely high in our NMO patients. And with that, thank you. I apologize. Kids are kids. You can't control them. Thank you very much, guys.
Thank you, Dr. Ahmed, for this excellent presentation. Your kids can mute their microphones, though.
I don't know. I need to figure out how to mute the kids, man. You know,
Yes.
I can mute me. I can't mute the kids. You know, that's, you know, the first person who does that gets a Nobel Prize.
Yeah, no problem. So please stay with us at the end for Q&A. Thank you, excellent presentation. We have already about 700 attendees. And for the attendee, please put your questions, submit your question on the Q&A button, not on the chat, and we'll be able to address your questions. And now we move to our next presentation. It's my pleasure to introduce and welcome and introduce our next speaker, Dr. Elias Sotirchos. He's Assistant Professor of Neurology, Division of Neuroimmunology and Neurological Infections at Johns Hopkins University. He's graduated initially from Athens, Greece, and then went further for fellowship and training in neuroimmunology. And his presentation will be on NMOSD overview of clinical trials and real-world experience. Dr. Elias, the floor is yours. We are happy to hear you.
Thank you so much for the invitation. I really appreciate it, and very nice to be giving this talk. I'm in a different time zone here, so it's late morning here. And thank you for taking the evening to attend this very nice meeting. And I'm going to follow up Dr. Shatila's talk, giving an overview of kind of a treatment approach and focusing especially on recently developed therapeutics and the phase 3 clinical trials that were recently performed in neuromyelitis optica spectrum disorder. These are my disclosures. And I just wanted to provide initially an overview. So Dr. Shatila did an excellent job presenting the clinical features of NFO. I just wanted to emphasize a couple of features that I think are important to take in mind when we are considering therapeutics for NMOSD. So as Dr. Shatila said, NMO is a relapsing disorder. And it is thought that if any neurodegeneration potentially or kind of progressive accumulation of disability that occurs can be exclusively attributed to relapses. And this is in contrast to multiple sclerosis, where relapses, generally recovery from relapses is fairly good, but progression can often occur independently of relapses and is thought to be the major substrate of disability in multiple sclerosis. In contrast, NMO is a relapsing disorder, and this is why it is incredibly important both to treat relapses aggressively as well as to prevent relapses from occurring in the first place, given the potentially devastating consequences associated with a spinal cord relapse or an optic neuritis, or again, brainstem or other areas that are involved. And the mortality can be quite high and the potential for permanent neurological disability as well. Just in terms of relapses, so the treatment is fairly standard in terms of the use of high-dose IV methylprednisolone, typically for 3 to 5 days, typically 5, depending on the severity of relapses. In NMO, where the relapse is often severe, we typically will do the full 5 days. And plasma exchange is often added for severe attacks or patients with a poor response to an initial corticosteroid response, if available. Now, apart from the treatment of relapses, what's most important is prevention. So a relapse can often, even with treatment with steroids and plasma exchange, recovery can be poor. So this is really the main focus of therapeutics in NMO at present, to prevent the relapse from occurring in the first place, especially given that we have the absence of therapies that can promote neuroregeneration and improve outcomes following a relapse and recovery. So In terms of the treatment approach, I think that it's important, first of all, to bear in mind that while NMO historically has been thought of potentially some cases being a monophasic disease, that has been called into question more recently. And especially patients for aquaporin 4-IgG seropositive should generally be assumed to be at risk for relapse indefinitely. And there is an accumulating body of evidence that patients who are aquaporin 4-IgG seropositive, if untreated, are almost certainly going to experience a relapse within the next several years. And additionally, if treatment is discontinued after a remission-free period, there are studies that support that also these patients remain indefinitely at risk of relapse and are likely going to relapse moving forward. So this is generally why we continue to treat indefinitely patients with NMO. Monophasic NMOSD, it's been doubted if that really exists, and especially given the recognition of the MOG antibody, directed against myelin oligodendrocyte glycoprotein, with clinical features that may mimic neuromyelitis optica, and in which case the disease course may actually be monophasic in a relatively large proportion of patients. Historically, if we look at the prior reports on monophasic NMO, it is quite likely that a significant proportion of those patients actually had MOG antibody spectrum autoimmunity rather than aquaporin 4-IgG associated autoimmunity. So that's important to bear in mind. So an additional feature that is very important and which was highlighted in the prior talk is that making the diagnosis as early as possible and making the diagnosis correctly is exceedingly important, since MS disease modifying therapies may be ineffective and even potentially exacerbate NMOSD, so increase the risk of relapse given their mechanism of action, which targets different mechanisms, immunologic mechanisms, which don't appear to be relevant in NMO and could even promote humoral autoimmunity with drugs such as beta interferons, natalizumab, sphygosine-1 phosphate inhibitors such as fingolimod and the other medications in that class, as well as alemtuzumab, haven't been reported in a number of studies to potentially increase the risk of relapse in neuromyelitis optica spectrum disorder. In terms of the historical approach to treatment, the most commonly used medications, and this actually remains the case even now worldwide, given the ease of access to these medications, has included rituximab, which is an anti-CD20 monoclonal antibody, and CD20 is expressed on the surface of cells of the B cell lineage, oral corticosteroids, oral steroid-sparing immunosuppressants such as azathioprine or mycophenolate mofetil, as well as tocilizumab, which targets the interleukin-6 receptor. However, until recently, these therapies that were available for NMO, which mainly included these and which had been used, the data were mainly derived from observational, non-controlled, or open-label studies. And there was a lack of phase 3 clinical trials in NMOSD in order to definitively support the efficacy of medications in NMO. And also the lack of phase 3 clinical trials precluded the formal approval of medications, including here in the United States from the Food and Drug Administration, for the treatment of NMO. So all of these treatments were being utilized off-label. I really like this figure from a nice paper from Sean Pittock in a review in Nature Reviews Neurology, in which they demonstrate here very nicely the mechanism of action of the medications used for NMO. And we're going to focus on the newer medications that have been currently approved in the United States, as well as rituximab, which has historically been the most used medication for treatment of neuromyelitis optica. So focusing first of all on the B cell lineage, which we see here on the bottom, we see the B cell maturation pathway initiating from stem cells and pro B cells all the way to the differentiation into the long-lived antibody producing plasma cells. And so rituximab targets the CD20 surface antigen of the B cells, which we can see here is expressed from the pro B cell to the mature and memory B cell phase of the differentiation. And so rituximab will deplete these cells from the circulation and largely deplete them also from lymphoid tissues as well in the bone marrow. And this is thought to be the main mechanism of action, depleting kind of the subsequent development of plasmablasts and plasma cells, which produce the pathogenic aquaporin 4 antibody and NMO. Now, one of the drugs that I'm going to discuss today is a drug called inebilizumab, which also targets B cells, but targets a different surface antigen, which is CD19, which is expressed on a similar subset of the B cells, but is expressed a bit more broadly. So it's expressed on the pro-B cells to the mature memory B cells that we see here, but also on plasmablasts and some plasma cells as well, potentially resulting in a more broader depletion of B cells. Another recently studied medication in neuromyelitis optica, and I will present the results from these trials, is satralizumab, which is an anti-IL-6 receptor monoclonal antibody, which has is similar to tocilizumab in that aspect, has a few different features, including a longer half-life, which permits monthly administration. And this targets the IL-6 receptor, which we see here is expressed in the terminal phases of B cell differentiation and is an important factor to support plasmablast and plasma cell differentiation, so also acting on the B cell pathways. And then there is another medication that I'm also going to be discussing, eculizumab, which is a medication that acts on does not act on B cells, but acts on a different part of the pathophysiology of neuromyelitis optica. And eculizumab inhibits the cleavage of C5 complement component into C5a and C5b. And this leads to the prevention of the formation of C5a, which is important. It's termed an allophilatoxin and has important chemotaxis effects in order to recruit inflammatory cells to a site of inflammation, as well as the formation of C5b, which forms the membrane attack complex, which can then poke holes essentially into targeted cells. Here, the target cell being the astrocytes, which express the aquaporin 4. Now, moving on, and this is the first study, phase 3 trial that was published in neuromyelitis optica in the New England Journal of Medicine in 2019. And I'm going to show here the design of the study, and notably the design of the studies overall across all 3 drugs were fairly similar in terms of that, given ethical concerns about potentially exposing neuromyelitis optica patients to prolonged periods of placebo treatment, given the potential severity of the attacks, the design generally involved the randomization of patients to the active drug and placebo in varying ratios. In this study, it was a 2-to-1 in order to minimize the exposure of patients to placebos as well. And then patients were followed for a period of time during which, if a patient experienced a relapse, they would then immediately be taken over into open label treatment. Also, this period of the double-blind treatment phase was somewhat restricted in terms of its maximum length, and patients would then be transferred over to the open-label treatment side in order to minimize the risk of a relapse in these patients. And these studies were powered, bearing in mind an analyze using a time-to-event approach, and then with a pre-specified number of relapses being included based on the power analysis. And that was and at that point, the study would be terminated after a pre-specified number of relapses had been experienced in the study. So that was the study design here. Here is the Kaplan-Meier curves of the relapse-free survival for these patients. We're going to focus on the left side first. So this trial, by the way, only included aquaporin 4 IgG seropositive NMOSD patients. So it did not include any seronegative or potentially MOG antibody positive patients. But this is the primary outcome of the trial and the primary analysis. And so this was the time to the first adjudicated relapse as established by an independent blinded committee. And what we see here is that during the follow-up, there was a marked decrease in the risk of relapse, about 94% in the eculizumab treated arm versus placebo. Now, one aspect of this trial is that this trial did allow the use of background immunosuppression. So patients were allowed to be on background immunosuppression, including things like oral corticosteroids and steroid-sparing immunosuppressive agents, but not medications such as rituximab. Patients had to be off rituximab for a washout period of 3 months or more in order to be included in the trial. So on the right-hand side, what we see is a pre-specified subgroup analysis of patients who were receiving monotherapy with eculizumab or receiving concomitant immunosuppressive therapy. And while the numbers were smaller in the monotherapy arm, here, what we see is that the results appear to be overall similar in the 2 groups, with a marked reduction in the risk of relapse in both groups. Now, moving on, the trial of inebilizumab had a somewhat similar design in which patients were, again, randomized to inebilizumab or placebo. Importantly, this trial included both aquaporin 4 IgG seropositive as well as seronegative patients who fulfilled the IPND 2015 NMOSD criteria. and also employed kind of a time to relapse analysis, and then an open label stage phase when patients would be converted following a relapse in the double-blind treatment phase. This trial did not permit background immunosuppression, the only exception being that patients were treated with oral corticosteroid regimen between the first 2 infusions of inebilizumab, so day 1 and day 15, and then tapered over a week. And that is because there has been a description that with B-cell depleting therapies, there may be a potentially paradoxically heightened risk of relapse early on after administration of B-cell depleting therapies. This has been described with rituximab. And so because of that, they aimed to have this oral corticosteroid overlap in order to potentially mitigate that. This trial also demonstrated a reduction in the risk of relapse and with a significant finding, and this was the pre-specified intent to treat analysis of all participants, including the majority of the patients being aquaporin 4Ig seropositive, but also the aquaporin 4Ig seronegative group, with a reduction in the risk of relapse based on the hazard ratio of 73%. And this was the analysis of the aquaporin 4Ig seropositive group, which was the pre-specified analysis, for which the reduction in the rate of relapse was 78%, as seen here, and we can see that was highly significant. Moving on, there were 2 trials of satralizumab, which, as I mentioned, is an anti-interleukin-6 receptor antibody. Here, the design was also somewhat similar. This trial here was the 1 trial, which was in the Human Journal of Medicine in 2019. This trial involved satralizumab, but permitted the use of background immunosuppression, similar to the trial of eculizumab that I mentioned previously. Patients were randomized in a 1-to-1 ratio to satralizumab or placebo plus baseline immunosuppression. And then similarly, in the context of a relapse, where would it be converted to the open label extension period where all patients were being treated, and again, also employed a time to event analytic approach in this study. Here we see the results from this study, which also demonstrated a very significant reduction in the risk of relapse in the patients who were treated with satralizumab. As I mentioned, this trial also included aquaporin 4Ig seronegative participants. On the left-hand side, we see the results from the analysis of all participants, which demonstrated a 62% reduction in the risk of relapse here. But when we restricted when the analysis was restricted to aquaporin 4Ig seropositive participants, the reduction in the risk of relapse was 79% with the use of satralizumab versus placebo. There was an additional trial of satralizumab. This one involved satralizumab monotherapy. So the prior slide that I just showed was it allowed the use of background immunosuppressants such as mycophenolate or other steroid-sparing immunosuppressants, as well as oral corticosteroids. In this trial, patients were similarly randomized to satralizumab or placebo. This was in a 2-to-1 ratio. And then during the double-blind period, patients experiencing a relapse would be then treated with open label therapy in the extension period of the study and would transition over. In this trial, similar to the trial that allowed background immunosuppression, there was a significant reduction in the risk of relapse, both in the entire population as well as the aquaporin 4Ig seropositive patients as well, with a reduction in risk of relapse being 55% in the all participants and about 74% in the aquaporin 4Ig seropositive subgroup. Just providing an overview of these results, and I didn't get too much into the secondary outcomes. There were a variety of secondary outcomes included in these studies, including MRI in the NMO study, which was the enablizumab trial, looking at pain, hospitalization, disability. However, overall, I mean, I feel that based on kind of our understanding of NMO as a relapsing disease, really the reduction of risk of relapse, which was highly significant and highly effective across all these studies, is really the main, I think, focus. And a lot of these studies were not really powered, I feel, to some extent in order to accurately assess some of these secondary outcomes. Now, these trials led to the FDA approval of all 3 agents in the United States for treatment of NMOSD. Importantly, based on the fact that the number of aquaporin 4Ig seronegative participants in these trials was quite limited, and they were only included in the trials of anabolizumab and satralizumab. The trial of eculizumab did not actually include any aquaporin 4Ig seronegative participants. There is a lack of sufficient evidence to support the use of these medications in seronegative patients. And so currently the FDA labeling in the United States includes only aquaporin 4 IgG seropositive patients. My understanding is that in the UAE, that the current approval, from what I was told, is for satralizumab and eculizumab currently have been approved for the treatment of NMO. Now, in terms of the route of administration, which is important when we're counseling patients and selecting an agent, eculizumab is administered as an intravenous infusion every 2 weeks following a loading period of 4 doses that are administered weekly. Satralizumab can be self-administered as a subcutaneous injection every 4 weeks following a loading period of 0, 2, and 4 weeks subcutaneous injections, whereas inavolisumab is an intravenous infusion that is administered every 6 months following a regimen of 2 loading doses that are given 2 weeks apart, similar to some extent to the regimens that are used for rituximab therapy frequently. Specific safety considerations that must be taken into account for these medications. Eculizumab, given that it acts on the terminal complement pathway, is associated with an increased risk of meningococcal disease. While in the clinical trials in neuromyelitis optica, no cases were observed, it is important to remain vigilant regarding this potential complication, which can be quite severe. And patients should be vaccinated for meningococcus. Here in the United States, the recommendations are to administer both the ACWY serotype vaccine, the quadrivalent, as well as vaccinate for meningococcus B at least 2 weeks prior to initiation of eculizumab, and or potentially use prophylactic antibiotics if the risks of delaying treatment are felt to outweigh the benefit. And one important feature here is that patients are often transitioning from eculizumab, from other immunosuppressive therapies to eculizumab when starting treatment. And so because of that, I often actually overlap with prophylactic antibiotics early on in the initiation of treatment. And because there is the potential for the vaccines to be less efficacious when concomitant immunotherapy is being utilized. For some of the other agents in terms of specific safety considerations, inavolisumab and satralizumab, both there is a recommendation for the avoidance of live or live attenuated vaccines. They're both contraindicated in active hepatitis B or active tuberculosis, and patients should be screened prior to initiation of therapy for prior hepatitis B exposure, which either evidence of hepatitis B4 antibody testing being positive or surface antigen positive and asymptomatically, or patients who have a positive tuberculosis screening should also be tested. And in that situation, appropriate consultation and treatment should be initiated, and the risk benefits ascertained, since these medications may potentially result in reactivation of hepatitis B or tuberculosis in these patients. Satralizumab is recommended also to assess liver transaminases and bilirubin due to a potential risk of elevated transaminases in these patients, and to be monitored periodically, as well as to monitor neutrophil counts. With inavolisumab, given as I showed the targeting broadly of B cells, including plasmablasts and plasma cells, immunoglobulin levels may decrease during treatment, and monitoring of immunoglobulin levels serially, as well as infection risks, is recommended. And depending on the trends of immunoglobulin levels, counseling of the patient for risk of infection and potential adjustments of therapy should be considered. Now, in the last few minutes, I just wanted to present one case which kind of highlights some of the things that we discussed, including both the potential risks associated with MS treatments in this population, as well as kind of the somewhat often difficulty treating neuromyelitis optica and potential risks for breakthrough disease activity. So this is a woman who I'm following currently in my clinic, who had presented actually initially in 1991. And this is about 14 years before the recognition of the aquaporin 4 antibody as the pathogenic antibody underlying neuromyelitis optica. And she presented with intractable nausea, vomiting, and hiccups, as well as neck pain and bilateral arm numbness. And this was not really recognized at the time to be a central nervous system issue. Based on the history, one would assume that she almost certainly had an area postrema involvement, as well as potential extension into the cervical cord, given the neck pain and bilateral arm numbness. Then over the following 6 years, she actually did well without recurrent attacks, but then developed right optic neuritis, was diagnosed with MS, and started on beta interferon treatment, with subsequently developing a very severe episode of cervical TM, tubercular transverse myelitis, leading to quadriplegia at nadir. And this kind of highlights this phenomenon of potentially some of the MS-related medications, including interferons, precipitating risk of relapse. And then she was switched to an interesting combination of Copaxone and methotrexate at the time, glutathione acetate, my apologies, methotrexate at the time. She actually did well on that regimen over subsequent years, and I suspect that this may have to do with the use of methotrexate, for which, again, it's a classical immunosuppressant. There is some evidence of off-label use of some of these immunosuppressants in neuromyelitis optica, but then experienced transverse myelitis and was switched to natalizumab, which also may lead to an increased risk of relapse in NMO based on descriptions in the literature and case reports and case series, and then shortly after that experienced another attack of transverse myelitis. Subsequently, was finally found to be NMO-IgG seropositive, given the availability of NMO-IgG testing at that time, and transitioned to azathioprine, which has been used off-label for several years for treatment of NMO, but developed an additional episode of transverse myelitis, requiring a switch to mycophenolate, continued to have attacks, even with the addition of rituximab, and then ultimately was actually a study participant in the PREVENT trial at our site, and actually had been randomized to eculizumab. We found this out after we were unblinded after the completion of the study. And this was administered in combination with mycophenolate. Following the initiation of eculizumab in combination with mycophenolate, she did not experience additional relapses. And ultimately, based on the trial results that I showed previously, which showed that eculizumab seemed to be effective both in combination with oral immunosuppressants as well as as monotherapy, we ultimately tapered off the mycophenolate, and until present, fortunately, she has remained on eculizumab monotherapy with no recurrent attacks. But I feel like this case is a somewhat interesting case, highlighting the use of both off-label immunosuppressants with some efficacy, apparently, that seem to result in some prevention of attacks, as well as the risks of MS disease-modifying therapies in this population, highlighting the importance of making an accurate and correct diagnosis as early as possible in order to prevent patients from accumulating irreversible neurological disability, and then the potential utility of some of the newer agents in this patient population. I'd like to thank you again for the invitation, and I'm looking forward to an interesting discussion and answering questions regarding this talk. Thank you.
Thank you, Dr. Sotirchos, for this excellent presentation. So, Dr. Ahmed, are you there?
Yep, I'm here.
No problem. We enjoy the spices of your kids, so they can be there.
Oh, khalas.
Well,
the little one went to bed now. You know, the problem is there aren't walls thick enough that absorb his screaming.
No problem. So we have many questions here on the Q&A bottom, so I can start by reading them. I'm sure you can read them also. But the first question was, in what criteria that NMO sometimes mistakenly diagnosed with multiple sclerosis? So Dr. Shatila, maybe this.
Yeah, I think I can answer that one. I mean, if in the setting when you have optic neuritis or transverse myelitis with the positive AQP4 antibody, and you've ruled out other things, it's NMO. The problem arises when you have someone with optic neuritis or even bilateral optic neuritis with this lesion in the spinal cord that kind of looks longitudinally extensive, but it's not very extensive, it's more of a patchy lesion. Then you start wondering, well, is this NMO, is this MS? I think those are the people that, even in the big centers, will scratch their head sometimes. It's not the AQP4 positive optic neuritis patients. It's the ones with the long lesions in the spinal cord, history of optic neuritis, or maybe you do VEP and you see both of them abnormal. And then to make it more confusing, you get a couple brain lesions on top of that. Those are the patients, I think, that make us scratch our head.
Yeah, thank you. So the next question from Balaji Nagarjan. If Elisa became positive and cell-based test became negative, so what your consideration of results? If you take neither negative or positive, or you can repeat them again. So Elisa positive, and then it becomes cell-based negative. Which one is the reliable one? Yes, Dr. Sotirchos?
I can take that question, yeah.
Yeah.
So I think that with the ELISAs, you have to be a little bit careful sometimes, and there has been reported, and I've personally seen cases of false positives with the ELISAs, especially when the titer is kind of borderline. That has been my experience. So these kind of borderline positive titers, you have to be a little bit careful. The cell-based assays are generally both more sensitive and more specific. However, I think that we have to bear in mind that also treatment potentially may affect the assay's sensitivity as well. So we see patients who receive steroid treatment and potentially plasma exchange. If you do plasma exchange, you're removing the antibody from the circulation, so the sensitivity of the test may be reduced. Additionally, patients who have been treated with long-term B-cell depletion, so they may be positive for the ELISA initially, then get on B-cell depletion for 3 years, and then you retest them with a cell-based assay and it's negative. I don't think that they do not have NMO anymore and that you made a mistake. I think that it's probably that the B-cell depletion resulted in seroconversion and made them negative. And so I think it's important, you have to be careful sometimes in interpreting some of these tests. And I think that that's why the clinical features that and imaging features that Dr. Shatila pointed out in his prior talk are very important when considering the diagnosis. So what is the appearance of the lesions? Is the lesion of the spinal cord longitudinally extensive? Are there lesions that look periventricular that look like MS? Presence of oligoclonal bands can be a hint, since oligoclonal bands are relatively less prevalent in NMO compared to MS. So you really have to take into account all of these features, I feel, in order to make the diagnosis. And just one last thing, I have patients where I'm not necessarily sure which one they have. And in those situations, I elect to use something like B-cell depletion, which I know will be likely beneficial for both conditions. And we have patients like that. And so in that situation, I feel like I should use something that covers both in order to hedge my bets essentially in that setting.
Thank you. If you have patient with general demyelinating disease, do you screen them for NMO, for aquaporine or such testing, aquaporine MOG antibodies, unless they have symptoms?
I tend to. I mean,
yeah.
All the patients who show up in my clinic will get screened for the AQP4 antibody. The MOG, anyone in the early 20s, teenagers, definitely I'm getting a MOG antibody. But the AQP4 now, because it's so easy and we have such a fast turnaround and the treatment decisions are so important, it can definitely make one disease worse or better. I get checked. I check it.
Thank you. So they recommend actually to screen all demyelinating patients, whether they are MS or not, for aquaporine and MOG antibodies. One question here is, thanks for the presentation. In subtype of NMOSD or MOGAD, is concurrent autoimmune disease common like NMO? I know. Transverse myelitis in MOGAD? Yes, please, Sotirchos.
Yeah, I can take that question. I think that this is kind of an area that's quite interesting. And there have been a number of reports recently, including a recent study from the Mayo Clinic where they try to look at this systematically. And I can say based on my experience that I agree with their conclusion. It seems like NMO is more associated with concurrent humoral autoimmunity. So patients with NMO will often have rheumatologic diseases such as Sjogren's or lupus. And even if they don't, a number of patients may have positive rheumatologic antibodies in the absence of clinical manifestations. So we see patients who have aquaportin 5G seropositive NMO, and they have a positive anti-Ro, for example, or a markedly positive ANA without lupus clinical manifestations. And so we do see this overlap with autoimmunity. Now in MOGAD, it seems that an overlap with rheumatologic diseases is much less frequent compared to NMO, so the presence of concurrent autoimmunity. One exception potentially to that is that there are patients described who have MOGAD who may have concurrent presence of anti-NMDA receptor antibodies. And so in patients with MOGAD who have had otherwise typical clinical manifestations, for example, optic nerve myelitis, there are some patients who may develop kind of an encephalitis-like picture, not an ADEM, but actually like a cortical encephalitis. And it's been described that these patients have may have NMDA receptor antibodies, and this is especially in children. And it seems potentially that maybe the MOG attack itself may induce a secondary autoimmune response due to epitope spreading or other mechanisms. And so that's something to bear in mind, even if you have a patient who you know has MOG, if you see them presenting with a prominent neuropsychiatric finding, seizures, things like that, bear in mind that they may have NMDA receptor antibody encephalitis on top of that. In terms of the transverse myelitis, so that does occur in MOGAD. It certainly can occur in isolation, although optic neuritis is the more frequent manifestation. In MOGAD, about 80% of episodes are longitudinally extensive, similar to an NMO, although some can be short segment. There are a few differences, both clinically and radiologically. One is that recovery is typically better. Radiologically, the lesions may be non-enhancing in the acute phase, which is less likely with NMO. And they may exhibit one sign that has been described as what's called the H sign, which is the involvement of a prominent involvement of the gray matter exclusively sometimes in MOG antibody disease. And the last feature that that has been recognized radiologically to be different is that the conus medullaris may very frequently be involved in MOG attacks to a larger extent than in NMO. So an NMO might often spare the conus medullaris.
Thank you, Dr. Sotirchos. Very nice answer. Question to both of you. You mentioned both about treatment of NMO with DMDs of MS. They worsen usually the NMO patients. And you mentioned about the mechanism of action. Can you elaborate more about this? Because it's a very sensitive and very important issue, actually.
I guess I can try, and then maybe Dr. Elias can pick up the pieces. I don't think we know why, fingolimod or tisabri, which is a self-trafficking molecule, makes NMO worse, but then interferons as well make it worse. And then alemtuzumab, which suppresses everything. Why does that make it worse? I don't know. But we do know that it does make it worse. But then again, we also know other DMDs don't, like DMF and Avagio, and then ocrelizumab. So I don't know of any specific reason why one class of drugs who have no one specific mechanism of action can make the disease work, while another set of drugs that have a different mechanism of action but have the same effect don't make it worse. Unless Dr. Elias knows something extra.
Yeah, no, I think that's a great question. I think that for natalizumab and fingolimod, I have to say it's not entirely clear to me. I think that we do have some idea for interferons and alemtuzumab based on kind of the immunology of those agents. So alemtuzumab specifically depletes T cells and B cells, and so it is a broad lymphodepleting agent. However, the B cells come back first after the depletion, and they may, in the absence of, there's a thought that in the absence of T cells and T regulatory cells, have a propensity for humoral autoimmunity. And that's why patients on alemtuzumab are at high risk to develop autoimmune syndromes in the following years after alemtuzumab, including thyroiditis frequently, autoimmune thrombocytopenia, Goodpasture syndrome has been described, and other autoimmune diseases. And so my thought is that in that situation, you're depleting the T and B cells, but then the B cells come back and they're unchecked by the T cells, potentially leading to humoral autoimmunity. And in an NMO, which is a humoral disease, you can make it worse. Interferons potentially skew a T helper 1 to a T helper 2 response, which can promote humoral autoimmune responses. And so there's a thought there also that potentially that might be the mechanism. Otherwise, for fingolimod and natalizumab, it's not entirely clear to me why that is, but I do agree that the case series and observational studies that exist currently strongly support that. And I've seen it a lot in clinical practice, patients misdiagnosed, put on one of those agents, and then having recurrent attacks.
Great, thank you very much. So there are two questions interrelated. Is NMO a form of multiple sclerosis? And what triggers NMO?
Different disease.
So please, you can share the questions, the answers.
Different disease. NMO is antibody mediated. We have an antibody. We have a test for it. MS, it's T cell, B cell mediated disease. We don't have a marker. Different, and they're not the same disease. We used to think they were, but they're not.
In the past, they used to say about NMO, it is the Asian multiple sclerosis, spinal form of multiple sclerosis, and later turned to be NMOSD rather than multiple sclerosis. Any comments, Dr. Elias?
No, I completely agree. I think that it's been well established now that the antibody is pathogenic. The pathological features, if we look at NMO lesions in the spinal cord, are clearly distinct from those of multiple sclerosis. So we should consider it a different disease.
We have some patients before 2008, before the aquaporine, they used to be diagnosed as autoimmune encephalitis, brainstem encephalitis, and same patient, they came later when the aquaporine was available and turned to be positive. So it was 10 years retrospectively, actually. So we have a question here from Fatma Al-Kindi. What are the predictors for rituximab failure or resistance in NMOSD? Predictors for failure of rituximab. Do we have?
I mean, I think that's a great question. We've tried to look at that ourselves. I have not identified a great predictor of rituximab failure. Overall, rituximab is fairly effective for NMO, although we don't have good large phase 3 trials in order to definitively ascertain that. There have been some small trials, including a recent one in Japan, but it was only 21 patients per arm, but no relapses occurred in the treated arm. However, there are certainly patients who do relapse on rituximab. I mean, the things that I have seen to be associated is one, failure to completely suppress B cells in the peripheral circulation. So there are some patients who may not fully deplete their B cells in the peripheral circulation. And that I've seen to be associated. And so then you might need to administer higher doses or more frequent infusions of rituximab, or consider use of a different medication. That is kind of one of the main situations. And this has been potentially kind of described in the past to be associated with a polymorphism and an FC gamma receptor that might result in suboptimal depletion of B cells in these patients. However, I'm not aware of studies systematically assessing that in NMO. I think that would be an interesting study to do, and then potentially kind of assessing these polymorphisms and saying like, oh, this patient is less likely to respond because of the fact that they're going to have suboptimal depletion of B cells based on kind of it would be an interesting kind of pharmacogenomic approach to treatment essentially. But that's been reported in some studies in other diseases to potentially be associated with a reduced depletion of B cells by rituximab.
Thank you, great. Again, question from Fatma Al-Kindi. What is the optimal duration of therapeutic plasma exchange if we need it in NMOSD? Duration of plasma exchange?
So we typically...
Yeah, okay, please go ahead.
I was going to say, because it was part of my talk, which was the therapeutic. I was just going to say, we typically do 5 to 7 sessions every other day for an acute relapse. We concurrently will pulse with IV steroids for 5 days. And then I will place the patients on oral prednisone, typically at around 1 milligram per kilogram or up to 60 milligrams, and then slowly taper that while initiating a long-term treatment and overlapping the steroids until we can get them onto a long-term treatment. But typically 5 to 7 sessions over every other day is the duration that we use for acute relapses.
And if the patient does not respond, if there is failure of Plex to improve the patient, what will be the next step?
That is a great question. I think that it's tough to say. I mean, I think that there is some rationale potentially for acutely administering something like a B cell depleting agent or eculizumab if you have access to it. Since eculizumab does target terminal complement, you could say potentially hypothesize pathophysiologically that could limit further damage. But I think that otherwise it's tough to say. I leave them on oral prednisone and time will tell. You need aggressive rehabilitation in order to kind of see if patients will improve at that stage.
This will take us to the next question by Sudhir. Any studies using stem cell therapy in NMOSD? Ahmed, you have center in Abu Dhabi.
We do.
Stem cell therapy. Do you have?
They're developing it, but it's not yet up and running. Mainly for malignancies, blood type cancers, but not for MS, not for NMO, no.
Okay. Any studies, Dr. Sotirchos?
I'm aware of only one study. I actually just pulled it up. It was from a couple of years ago in neurology. It was a case series from a group in Chicago in the Mayo Clinic, where they had several patients who did receive autologous hematopoietic stem cell transplantation with NMO. It was 13 patients actually. And there was report of potentially having a prolonged drug-free remission in these patients, but the median follow-up was almost about 6 years, and it was only 13 patients. And so it's difficult. I feel. I think that there's there's a lack of evidence overall, and we also here do not use that.
Yeah, thank you. Question here: what is the safety of COVID vaccine in MOSD patients and the risk of relapse? Vaccination, COVID vaccination, is it like multiple sclerosis? There is no risk of relapse in MS. We recommend all MS patients to be vaccinated. Does this apply to NMOSD?
I don't know of any restrictions with COVID vaccinations and NMO.
Yeah, okay.
Similar here, it seems to be safe in NMO, and if anything, I strongly urge all my patients to be vaccinated, since again, these medications are immunosuppressive, so they are likely at a heightened risk of more severe COVID-19 if they are to become effective. However, this brings up one point that potentially COVID vaccines may be less efficacious with specific types of therapies. So B-cell depleting therapies, there are a lot of studies in multiple sclerosis and other autoimmune diseases that show that patients who are vaccinated while on those treatments, they have undetectable or low-level antibody responses, especially if administered in the first few months after rituximab or other B-cell depleting therapy dose. And so generally we try to time the vaccines to be at about a month before an infusion is due in order to increase the potential for an antibody response. And also, I'm not sure if this is available in the UAE, but I actually have given several patients monoclonal antibodies that have been approved for prophylactic use. So if patients are antibody negative, COVID antibody negative, despite vaccination and are on B-cell depleting therapies or other immunosuppression agents such as mycophenolate, then we can give monoclonal antibodies, which is called Evusheld, and it has an emergency use authorization in the United States for prophylaxis. And the studies support potential protection for up to 6 months following injection. Now, otherwise, I think that there's a kind of an interesting point that of the available therapies for NMO, eculizumab and satralizumab do not seem to affect vaccine responses to the extent that B-cell depleting therapies do. And so in the era of COVID, I think that that's an interesting kind of thing to take into account potentially, that vaccine responses with those two agents may be preserved compared to B-cell depleting therapies. And then finally, just in terms of relapses, we have urged all our patients, we have not seen a spike in relapses with COVID vaccination in patients with NMO, especially on treatment. And there are some small studies that have been reported today reporting experiences and surveys of patients with NMO that reported a fairly good safety profile and no clear evidence for a heightened risk of relapse.
Thank you. For B-cell depleting therapies, we follow the same for vaccination. We give COVID vaccination 4 weeks before or 4 months after receiving the B-cell, whether rituximab or ocrelizumab. Or Ahmed, you want to tell something?
Yeah, actually, I have a question. Going with the whole idea of secondary or concomitant autoimmunity. That patient I was talking about, I briefly alluded to in my presentation. She presents with optic neuritis, transverse myelitis, hiccups, but then again, she was in Denver last year and someone diagnosed her with Lyme disease. Even though she never had the rash, she had some weird arthralgias, but she never had rash, but someone told her you have Lyme and we're going to treat her as Lyme. So have you ever heard of that? Secondary positive Lyme results with NMO patients, or is that really, she probably did have Lyme and she does have NMO?
I have a couple patients who have Lyme. Now, again, I'm in the mid-Atlantic, and so Lyme is very prevalent here. So I'm not entirely sure if that's by coincidence, by chance, that patients have had Lyme potentially and NMO, because it is highly prevalent in our area. One thing to ascertain there would be that there is a community of people who believe in chronic Lyme in the United States. And there are some doctors who run these sort of Lyme practices where everybody who gets tested will be positive for Lyme. And it's not really the test that is the CDC kind of recommended test that we use for Lyme. So that would be just one thing to be aware of, that sometimes this occurs in the United States. But I think that it's interesting. I mean, we've seen some patients having demyelinating disease that seems to be triggered by infection. We recently, but I have to say, I feel like that's more frequent in MOG antibody disease rather than aquaporin seropositive NMO. So in MOG antibody disease, about 50% or more of patients have an infectious prodrome or a vaccination preceding the onset of the disease potentially. And we've seen patients like that. We actually published a case report last year also of a patient who had asymptomatic latent syphilis and developed MOG antibody disease following treatment of the latent syphilis with a kind of Jerish-Hartzheimer-like reaction and then developed kind of this acute demyelination, an ADEM-like picture, and was found to be markedly MOG antibody positive. So my thought is that potentially the treatment and the inflammatory response of the latent syphilis may have triggered a secondary immune response leading to secondary demyelination and development of MOG antibody disease. So I think there's a strong rationale that with Lyme, you could get a similar phenomenon potentially as well.
Okay.
Yeah, I think Lyme is very rare here, isn't it, Ahmed?
It is rare, yeah. But the
yeah.
thing is, she was in Denver, Colorado last
Okay.
year. That's where the whole Lyme thing, I mean, in UAE, no, we don't see Lyme, but
yeah.
she was in
have
Colorado, and she had, I'm like, really, Lyme? And we don't get that here.
Okay, great. So our question from Majid Habahbe. How soon after the onset of attack do you consider PLEX? Do you start immediately after IV methylprednisolone, or you wait for some time? This is the dilemma always. Do you start PLEX immediately if there's severe attack, or you spare it later if patient does not improve with steroid? So attack sorry. Okay.
No. Oh, sorry. So I think that there's equipoise. I don't think that there's a right answer. I know some people do steroids and then wait. And if there is no response to the steroids, then they will do plasma exchange. I personally am a bit more aggressive than that. If I have a patient in front of me who came in and has a severe attack, let's say longitudinally extensive transverse myelitis with inability to ambulate or severe bowel bladder dysfunction, I start steroids and PLEX concomitantly, actually. And importantly, there are studies that have monitored kind of steroids in blood and plasma and levels in the body, and it's not thought that plasma exchange affects the effects of steroids in the body. So you can do both concomitantly without being concerned that you're removing the steroids or anything like that, because they rapidly diffuse to their area, to the target in terms of action. That's my personal approach.
Yeah, do you keep them on oral taper steroid after that?
Yes, I keep them on oral taper until we get them onto a long-term therapy. So all my patients are going to be on steroids, at least more than 20 milligrams of prednisone. I'll start initially with 1 milligram per kilogram, slowly taper and remain on at least more than 20 until we get them on a long-term treatment. And the other thing I do is I also overlap the steroids with the long-term treatment, since it seems that there is some evidence that the B-cell therapy, depleting therapies, also potentially the interleukin-6 receptor blocking antibodies, they take a few months to have their full effect. So I typically overlap steroids for at least 3 months. One exception to that is eculizumab, since eculizumab really results in immediate kind of inhibition of complement. So I feel with eculizumab, you are able to taper steroids more rapidly, but otherwise I overlap for at least 3 months.
Okay, thank you. One question here: why doctors is very sure that after 5 years the patient with NMO becomes blind? Why you are sure? We are not sure that they become blind. There is treatment for this. I have one patient who was having myasthenia gravis and NMO, and she went blind because she refused any treatment. And that was maybe more than 20 years ago. So nowadays, I mean, with the recent therapies, they shouldn't go blind. Did I answer this question? Yeah, please.
I think, that's referring to untreated NMO, or historically how these patients did, before we knew how to treat these patients. Yeah, a lot of people went blind, a lot of people were disabled, and the significant people died within 5 years from respiratory failure or secondary infection. Now, we don't see it as much, but we're not sure. But I think that was pre-treatment.
Yeah, thank you. I think we'll take 2 or 3 more questions because of time. Is NMOSD completely curable or not?
So I wouldn't say it's curable. I mean, but I have to say that the treatments that are currently available are highly efficacious. And I have patients who have been on treatment for over a decade and are leading a normal life and have not experienced a relapse since being on treatment. So while, yes, we don't have a medication that can cure you and then you don't need to take it again, I would argue that we have very good options right now, and that they can maintain our patients relapse free and mitigate the risk of long-term neurological disability to a great extent as long as they remain continuously and indefinitely on those treatments.
Yeah, great, thank you. One question here, does the titer of antibodies of aquaporin and diamine will affect your diagnosis regarding NMOSD? Is it positive, negative, high titer, low titer? How is it? This is the question. Yes, please.
I'll say that.
Yeah, please.
Say that first of all, the titer has not necessarily been shown to correlate well with the risk of relapse and disease activity. So that's an important feature. And secondly, the titer might influence me for the ELISAs. So as I said, the borderline ELISA titers, especially if the clinical picture is not entirely consistent, I'm skeptical of. But otherwise, the titer in and of itself does not really affect me. If it's positive on a cell-based assay and the patient has a compatible clinical picture, the diagnosis for me is NMOSD.
Yeah, and I was going to say, actually, we send our AQP4 antibodies to Mayo, and usually it just comes back positive and negative. It doesn't, they do cell-based, they don't give us a titer. So I guess cell-based doesn't have a titer, but I've never seen a titer on my AQP4 patients. That's why I was like scratching my head a little bit.
They write usually, they write usually less than 10, higher than 10, lower than 10. It's not like monoclonal antibody. They say 9 bands, 5 bands. This is what the report's getting from 2 European centers.
Yeah, for us, it's just positive, negative from Mayo.
Yeah, okay. So another 2 questions from Fatma Al-Kindi. Who you prioritize the new agents in the immunotherapy protocol? So I think first line, second line, what are the best patients for the new therapies? All NMO patient, or they have to fail rituximab, first Imuran, fail Imuran, Celcept, and then you go for it? What is the approach?
I think
Sotirchos.
it's a complicated question, I guess. There's multiple layers. I mean, you know, if you want to go with strictly FDA, it's the 3 medications we have. You want to go with financial, it's rituximab, Imuran, Celcept. I mean, if you want someone with aggressive disease, it's eculizumab. But then again, they got to come every 2 weeks. So I think there's multiple layers, and there is no one size fits all. But you know, we got to look at cost. We got to look at what the patient wants, where they live, and what kind of life they want to live. But I don't think every NMO patient is going to get every drug.
So let me phrase the question a different way. If you have a patient taking rituximab and he's doing well, no failure, well, every 6 months taking the dose and no disease activity, still you think of changing his medication?
No. If he's doing good on Rituxan, I wouldn't change.
Dr. Sotirchos?
If it ain't broke, don't fix it.
Yeah.
Well, I agree. I think it's a complicated question overall. I do agree that for patients who are doing well on a medication that they've been on for a while and are not experiencing significant side effects, I also kind of agree. I agree with Dr. Shatila. I would consider switching if there were things like either a relapse or safety issues potentially, such as developing hypogammaglobulinemia and recurrent infections. I think that would be an incentive. Now, more interesting, I think, is new diagnoses and how to handle them now in the era where we have this expanded armamentarium of therapies for NMO. And I completely agree. There is no one size fits all. I don't have kind of a fixed approach that, I'm going to use this medication first line and then only if they fail, go to the second. Because I think that there are layers of this. So one is, for example, the route of administration. Some patients don't want to self-inject, for example. Some patients are not have a travel schedule that does not permit an administration of a medication every 2 weeks. So there are kind of multiple layers there. Then I think you need to take into account comorbidities and the risks associated with the treatment. So potentially, if patients have a history of hepatitis B exposure or latent tuberculosis, that might kind of affect your selection of therapy as well. Also, if they have comorbidities and are at risk for things like lung infections, other things like that, if they're older and have, so I think that it's a complex decision, and it's kind of like one of those things where you need to have a detailed discussion with the patient, and a shared decision-making becomes important to some extent.
Thank you, great. We'll take the last question here. Can NMOSD cause infertility?
Not to my knowledge.
That's a great question. I mean, I'm not aware of infertility and the therapies that it's a complex discussion to be had about pregnancy and the effects of these medications and the potential usage of them. But in terms of NMO itself, NMO itself has been associated with an increased risk of miscarriage. Sometimes patients, as I said, can have overlapping rheumatologic syndrome, such as lupus, and can have things like antiphospholipid syndrome, which might predispose them to miscarriages. And then there is some kind of studies that support that aquaporin 4 is expressed on the placenta, and perhaps that is associated with an increased risk of miscarriages. But otherwise, in terms of fertility itself and ability to conceive, I'm not aware of a study supporting that, only kind of the potential for somewhat higher risk of miscarriages in this population.
Yeah, thank you very much. At least now for NMOSD, we have 3 approved medication. One of my colleagues prescribed rituximab for NMOSD. The insurance refused. They said this is off-label. So what she did, she wrote satralizumab. They started shouting, come, we'll give rituximab because of the cost. Maybe she's hearing now. So with this, I think we'll end this because we're already cutting our time. I want to thank the speakers, Dr. Sotirchos and Dr. Ahmed Shatila. I want to thank the biologists, the organizers, and the MCO. And you see it on the screen. So you receive the CME certificate within 2 weeks after you do the evaluation, which will come to you on your email. So thank you all. Thank biologists, speakers, and all the audience, of course. We reached more than 850, which is great, really. And thanks for MCO for organizing this. Okay.
Thank you, everyone. Thank you, Dr.
Have a nice
Elias.
day. Yeah. Good night for the region and good day for Dr. Elias.
Thank you,
Thank
Dr.
you.
Jihad.
Start a good day. Okay.
Good day, Dr. Elias.
Okay.
Bye.
Bye. Take care.